say nurses too.
Oh.
Teaching medical students and SRNAs. She is board certified since 1997, and she's also an examiner on the American Board of Anesthesiology and vice chair of clinical affairs. So we're very, very lucky that she's here. She's going to talk about Anesthesia 101. We are taping this, so if you ask questions, just make sure they're loud enough, or we'll try to keep.
Yeah, or I'll try and repeat them.
Because we're going to use this for orientation, so feel free to ask any questions. And we'll let Sheila go ahead and talk. Thank you so much for coming.
Thank you. Again, if you have questions, just speak up. We can go as we go along, or we can do questions at the end, however you want, so don't hesitate. I'm pretty sure none of you have had any problems interrupting me before, so we're comfortable with that place there. Okay, so Anesthesia 101, some of it's a little more detailed. It's really Anesthesia 201, but we'll get started here. I don't have anything to disclose. You've heard my background here, and here's our objective. So we'll get started. The different types of anesthesia, we've got what's listed in the schedules. We have local anesthesia, moderate conscious sedation, monitored anesthesia care as MAC, regional anesthesia, and general anesthesia. And the reason I have local anesthesia and moderate sedation listed in green is because when those are scheduled that way, that means that there's not someone from the Department of Anesthesia that's involved. So monitored anesthesia care is kind of the level at which an anesthesia provider is involved. And our definition of MAC actually doesn't depend on the type of medications given or the level of sedation. It's really just having an anesthesia provider involved with a patient who is not at a level of general anesthesia. Dr. Heiser is going to talk on regional anesthesia, so I'm skipping that section completely. And general anesthesia doesn't mean that somebody has a controlled airway. We can have general anesthesia with spontaneous ventilation. General anesthesia refers more to a patient's ability to have any purposeful response. So just a quick thing on local anesthetics. There's two main classes of local anesthetics, ester and amide local anesthetics. The easy way to know if you look at a drug name, is it an ester or an amide, is that before the cane part of the word, if it has an I in it, it's an amide, because amide has an I. So bupivacaine, lidocaine, ropivacaine, prilocaine, they all have an I, so they're amides. Benzocaine, cocaine, procaine, and tetracaine are the more common ester local anesthetics that we use. If a patient says that they are allergic to local anesthetic, and they say, I'm allergic to all canes, it's very rare to have an allergy to an amide local anesthetic. So the far more likely effect is that the person has an allergy to an ester. Those are not uncommon to have allergy to local ester anesthetics, but the other thing to remember when somebody says that they have an allergy to a local anesthetic or they're allergic to a cane is find out what their reaction was. Many times people will say, they made my heart race. Well, then what happened is they had effect of the epinephrine that probably was in the local anesthetic. So that's the more likely thing that we see. And we don't use Emlicreme very often, but Emlicreme is a combination of two of the amide local anesthetics. That's lidocaine and prilocaine mixed together. So those are both amides, so they're okay for someone who has an ester local anesthetic allergy. This is the language that is on the medical staff policy on moderate and deep sedation for the Nebraska Medicine medical staff. So it's MS-15 if you want to look it up, but the levels of sedation are defined here. Minimal sedation, anxiolysis. We still need to consider that those patients may have impaired coordination and cognitive function, but should have really no cardiovascular effects. Moderate or conscious sedation has some depression of consciousness, but a purposeful response to verbal commands and should not need any intervention to maintain an airway. In other words, they have adequate spontaneous ventilation. Deep sedation may have a purposeful response to repeated or painful stimulation, may need intervention to maintain an airway. But the key point on deep sedation is we generally consider those patients to be at great likelihood to have inadequate airway or inadequate spontaneous ventilation. And then general anesthesia in this policy is defined as a patient who's not arousable even by painful stimulation. So they may still have spontaneous ventilation, they will probably need airway support, and may have some derangement of their cardiovascular and ventilation system as well. When we look at sedation, the real issue is to be aware of the fact that you need to be prepared to manage a patient at one level deeper than the intended level of sedation. So if you are if we have a patient that's undergoing moderate sedation, we need to be prepared in terms of equipment and ability to respond to someone who slips into deep sedation. The same with deep sedation, we have to be able to rescue a patient from general anesthesia. So monitored anesthesia care means anesthesia is monitoring the vital signs, may or may not provide any sedation or analgesia, but the vast majority of the time that we do. But one of my favorite quotes from anesthesia come from Dr. Wei-Ling Pong, that monitored anesthesia care means all we are required to do is monitor. And I witnessed her saying that statement, taking care of a patient who was 1,000 pounds plus. And she literally took out of the drug tray anything that could potentially cause sedation, any change in cardiovascular function, or any change in ventilation status. She literally took the step of taking the meds out of the resident's hand, and the resident says, "But we're doing monitored anesthesia care," and she says, "That's right, all we're required to do is monitor." So, so this is the kind of a true definition of monitored anesthesia care. I know we get into some issues here over what locations a patient can go to after having monitored anesthesia care, and that's something that we need to be aware of at each location that we're working at. Can this patient be safely recovered in an area when they had a MAC? But just remember, it can be a really wide variety of actions that had occurred while under monitored anesthesia care. So some of the common medications that we are using in MAC cases, again, our goals are anxiolysis, sedation, amnesia, and analgesia. So for anxiolysis, primarily we're using benzodiazepines, and those are midazolam, lorazepam, and diazepam. I'm going to lapse into using trade names here because they're so much easier to roll off the tongue. So by far and away, the thing that we use most is Versed. We rarely or will ever give Ativan for a MAC case, and same with Valium, and I'll talk a little bit more about those in detail. Another medicine that we're using on occasion for sedation in monitored anesthesia cases is dexmedetomidine, or Precedex. It is a great anxiolytic drug. It's also got some good analgesic properties, but it's very expensive, and it's a little bit of a hassle to work with because it's a continuous infusion that you can't really titrate as easily. So we use it on occasion, but it's not our first line choice for anxiolysis. And again, I'll talk more about these drugs in detail. For sedation, our primary drug is propofol. We're also using benzodiazepines for sedation and dexmedetomidine. Really the only amnestic drugs we have are the benzodiazepines. And an important point to remember about those is they only produce amnesia after the time that you give them. As much as we would love to have retrograde amnesia at times, they aren't going to be effective until you actually give the drug. And then for analgesics, we're relying on opioids. A key point to remember is that propofol does not have any analgesic property. The only way that people are not responding when they're having a painful procedure is because they're at a deeper level of sedation. It's not because propofol provides any analgesia itself. So benzodiazepines are drugs that work on the central nervous system. They're very lipid soluble, which is how they get into the brain and the central nervous system. And their action is on GABA receptors. And the greatest location density of the GABA receptors is in the cerebral cortex. So that's why they primarily have CNS actions. And again, they're sedatives, anxiolytics, provide antegrade amnesia, also very good for anticonvulsants. Apparently we had an issue with that just about 24 hours ago. So there was some Versed on the line when a patient had a seizure from a local anesthetic toxicity. So they used the Versed to treat that patient. And then they went on to use appropriate treatment for with intralipids for local anesthetic toxicity as well. But they did the appropriate thing and used the drug that was good for that they had at hand at the time. Now, one reason we really like benzodiazepines is they have a really good safety profile. They do produce minimal depression of ventilation, according to the textbooks, although we've all seen far more than minimal depression of ventilation. But again, we have to remember that they can cause transient apnea after administration, and that's always something we very, very much need to watch out for. So if we're comparing Versed, Ativan, and Valium, those are the top line, the 0.1 to 0.3 milligrams per kilo of Versed is an induction dose. So we're talking about induction of general anesthesia. In general, when we're doing sedation, we're doing it at a half milligram to up to 2 milligrams at a time. What I like to tell the anesthesia providers when I'm teaching residents in SRNAs is it is always easier to add more than it is to take away when you give too much. So when we start with a patient, I like to start and give them a half milligram to 1 milligram and see how they respond, especially someone who maybe already has other medication on board or who is elderly. It's far easier most of the time to start slow and add instead of overdoing it right from the beginning. The great thing about these drugs is they take effect very quickly. So we can easily see if we need to add more. You give a dose of Versed, you should get an effect within 2 minutes for someone with a normal circulation time. Ativan, longer onset of action. Valium actually, this is what the textbooks say, their onset is 30 minutes. IV, I think we see it far faster than that. I think we see really you can see an onset from Valium in 5 to 10 minutes. But its duration of action is going to be, you know what, that's the problem that I have. I have the duration and for the Valium, I have these two mixed up. So onset is 15 to 30 minutes, duration is 2 hours. My apologies, that's a screw up on the slide there. So duration of action of Versed, very short acting, 15 to 20 minutes, maximum 30 minutes after a dose of Versed. So why do we tell people that they can't drive for 24 hours after they've had Versed? Because we don't know how everybody's going to respond, and generally they are also getting other medications that are going to be synergistic. So if they're getting narcotics and things as well, we are just using an abundance of caution and telling them that they have to have someone with them and can't drive or do anything dangerous for 24 hours. The key points are for Versed, we like to use it for oral premedication, very well absorbed through mucosa. We can also give it intranasal if we have to. And so definitely less postoperative sedation. Ativan causes venous irritation and thrombophlebitis, as does Valium. It is not water soluble, so it's very irritating to the veins as it's going in and is painful on injection. For the half-life of Valium, you have to consider it to be at least 24 hours. In an elderly patient, say someone over the age of 70, consider the half-life of Valium to be their age in years. So if you give Valium to a 70-year-old, it's going to last for 3 days. It's going to last about 70 hours. So that's why we just really don't use Valium very much. But when we give a drug, it's always great to have a way to fix the overdose, and we're lucky that we have an antagonist for benzodiazepines in flumazenil. The dose of flumazenil is 0.2 milligrams. You can give that every 1 to 2 minutes up to a max of 3 milligrams until you reach your, or what we want for a reversal of sedation. But flumazenil has a very short duration of action. Based on how much of it you give up front, it's going to only last 20 to 60 minutes. So if we've given a longer acting benzodiazepine or a very large dose of benzodiazepines that are taking a longer time to be cleared, maybe in somebody with some, say, renal dysfunction, we need to remember that they may have a risk of resedation, and the flumazenil may need to be redosed then. So if this is a chart of patients who were healthy volunteers receiving Versed infusions, their rate is down here, 0.06 to 0.2 milligrams per kilo per hour. So it's about 2 milligrams an hour of an infusion, but they gave flumazenil to these patients. If they just gave 0.2 milligrams while they were still receiving the Versed, they didn't even get up to what they would consider full alertness on the awake. When they gave higher doses, 0.6 and 1 milligram, they had a peak. They all woke up, but then in about 40 minutes to 60 minutes, they were resedated again. So higher doses will give you a longer duration of the flumazenil effect, but remember that it's still not going to be a substantially long-lasting drug. So you may need to titrate it and redose. We talked a little bit about dexmedetomidine, or Precedex. Its class is an alpha adrenergic agonist. So primarily it's approved for use in patients on ventilation in the intensive care unit. It's very good at producing sedation, anxiolysis, and some analgesia because of its alpha adrenergic effect. It's been shown to decrease the need for narcotics by about 50%. So for patients who are at risk for having respiratory depression due to obstructive sleep apnea and combined with narcotics, Precedex is a very good drug to allow a lower administration of narcotics and hopefully decrease the risk of postoperative respiratory depression. We are using it a fair amount as an adjunct to some types of MAC cases. I've seen it used in, say, vascular surgery, where we want the patients to not have respiratory depression, but it would be at risk to put them on a ventilator. And we frequently use it for awake intubations, awake fiber optic intubations, because they'll maintain some spontaneous ventilation, but have a very good sedation and analgesic time during that awake intubation. So we use that on occasion. Frankly, we don't use it as much as we would like to because it's really expensive, and so pharmacy is not all that keen to release it to us. There's the induction doses, so there's a loading dose, and then the infusion is about a half to a third of what our induction dose is. Really short half-life, about 4 minutes, and primarily metabolized by the liver. It does decrease cerebral blood flow, but it doesn't change the intracranial pressure, and is really produces a state very much like physiologic sleep. Some decrease in blood pressure due to decreased heart rate and stroke volume, or systemic vascular resistance. So if we move on to general anesthesia, the anesthesiologist mantra, we like caffeine in general. So the 3 stages of anesthesia that we talk about generally are induction, maintenance, and emergence. And if we think about anesthesia, a lot of times we compare it to flying. So it's very similar to takeoff, in-flight, and landing. But for induction, there can be 2 types. If we have IV access, we do an intravenous induction. For patients that we don't have IV access, we can do an inhalation induction using the anesthesia gases. And the same with maintenance of anesthesia. We, the majority of the time, are using anesthesia gases for maintenance, but on some cases we're using total intravenous anesthesia, or TIVA. and then emergence is very similar in both types of anesthetics of IV or inhalational. So we don't talk about this a lot, but I think this is really important to think about the stages of anesthesia. So when we start giving someone anesthetic medication, we start with the induction. And then as patients are moving into a level of deep anesthesia, they go through excitement phase. We don't see that a lot now, moving from a awake patient to an asleep patient, because the medications we give are so fast acting. We're generally moving through the excitement phase fairly quickly. It is something that we see when we're doing an inhalation induction, because that does take longer. So sometimes we'll see the excitement phase then. And then we get down to the level of surgical anesthesia, and there's different planes of surgical anesthesia, from eye movement to loss of corneal and airway reflexes, pupillary reflexes go away, and then the last thing that goes away is the diaphragm and intercostal muscles. I think the body is such an amazing, such an amazing structure. It really resists not doing what it's supposed to be doing. So when we're doing a cardiac case and we need the heart to not beat, we have to give it massive doses of cardioplegia, primarily potassium, to stop the heart from beating. And if you don't keep replenishing that, 30, 40 minutes later, the cardioplegia has washed away and the heart will start beating again. Well, the same with ventilation. The diaphragm wants to move. The intercostal muscles want to move. And if we don't give neuromuscular blockers, if we're just relying on the stages of anesthesia, the first thing that happens is the body wants to start breathing again. So sometimes I can get just a little bit snarky in the operating room when a case is finishing up and the patient is breathing spontaneously, and the resident looks up and says, "The patient's waking up." And I go, "Oh, really?" Because you can tell that when the patient's starting to breathe, that their brain is also waking up as well. I said, that to me, I've just moved from stage 4, or the 4th level of stage 3 of anesthesia, up to the 3rd level of stage 3 of surgical anesthesia, and I can't tell what the brain is doing. And then they usually get kind of humbled and they go, "Well, I didn't mean waking up, I meant the patient's breathing." And then I say, "Well, then you'll have to learn how to sew on a breathing patient." Because we're still in a really deep level of surgical anesthesia, even when the patient can be spontaneously breathing. And in fact, the last thing that happens after we have enough anesthesia on board that the diaphragm does not move is overdose, which is also called impending death. And that's literally what they call it on these stages, is imminent death. So if we look at, here's muscle activity respiration, we've got normal intercostal and diaphragmatic activity. In excitement phase, they're somewhat uncoordinated, and this is why we worry about the excitement phase, and then finally the movement goes away. Eye movement goes away early in stages of anesthesia. The pupil size changes. We go from normal to, in the middle of deep stages of anesthesia, you get really pinpoint pupils. Even if we haven't been giving much for narcotics, you'll still get a narrowing of the pupil size. The concern is if you're really deep at anesthesia levels, then the pupils will dilate again. Eye reflexes go away early, at least the lid reflex and the corneal reflex, and we frequently will test that. We'll just reach up and brush against someone's eyelashes to see if they're deep enough that we can start instrumenting their airway and taking over breathing for them. But the key point to remember for you especially is, if these are the stages that we start with anesthesia, we go back up those stages as we emerge from anesthesia. So we frequently will be concerned about the excitement phase. The reason we're concerned about excitement phase is that's a great risk for airway issues like laryngospasm, bronchospasm, coughing, sputtering, losing their airway. So we need to pay attention to patients potentially be going through excitement phase before they get back to being wide awake. The intravenous anesthetics that we have, primarily the one that we use nowadays is propofol. Just as a side note, because it's the most commonly used drug and also one of the most easily accessible, it is now the most abused drug in anesthesia as well. But we use it both for maintenance, induction of anesthesia, maintenance of anesthesia, and MAC cases. It has the emulsion that it's in has soybean oil, egg yolk, and glycerol in it. So that's about the only time that I really pay attention in anesthesia when somebody says that they have a food allergy, is if they have an egg allergy. If somebody knows specifically that they are okay with egg yolks but not egg whites, potentially they could get propofol, but generally we stay away from giving it to anybody who has a true egg allergy. But because it has these substrates in its emulsion, it does support bacterial growth, so it really should only be used within 6 hours after opening of the vial. It should be drawn up in a fairly sterile technique. It has rapid onset. It is essentially one circulation time if you give a big enough dose. So it's easy to titrate because we can see an effect, and if we don't have enough of an effect, we can continue to add more or increase the dose of the infusion. Very short duration of action. Even after a very large slug of an induction dose, people will be awake in 8 to 10 minutes. If we're running a lower level of an infusion, most patients will be awake within 5 minutes. So it doesn't have accumulation. You can run a propofol infusion for a very long time. We've done some cases where the patient needed to have a total IV anesthetic and the case has gone on for 15 hours and the patient wakes up generally within about the same time frame as a much shorter infusion. We see it used many times for sedation in the intensive care unit for patients on mechanical ventilation, and doesn't have a prolonged wake-up effect after shutting off a prolonged infusion. Again, just want to reiterate, propofol is not an analgesic. It does not have any analgesic properties. And we do see patients complain of pain when we first start to give it. That goes away in a few seconds, even if the infusion is continuing. Some people have tried giving lidocaine with it, or a opioid through the IV right before giving the propofol. Those things have kind of hit or miss opportunities to decrease the pain. The best things are to decrease pain is use the biggest IV that you can, and the more centrally located, like an antecubital vein, has less pain on injection than a hand vein, but otherwise we don't really have any good ways to stop the pain when we start the propofol. Biggest thing to remember about propofol, it's a profound vasodilator. It will decrease blood pressure. So if we give it in a large enough dose, even on somebody who is hemodynamically stable and has an adequate volume, they'll still drop their blood pressure. If we give it to a patient who is hemodynamically unstable, in shock, low volume, bleeding, sepsis, issues like that, we'll get a pretty profound decrease in blood pressure. Causes apnea and respiratory depression, so that's why propofol is limited in who has access to it. So in this hospital, anesthesia, the only physicians who can give it are people in the critical care units for patients on mechanical ventilation. The oral surgeons can give it in their clinic. If there's a lot of kind of restrictions on that, but they do use propofol on occasion for sedation because they have done significant amount of anesthesia training. But we're generally not open at this point to, say, letting the GI doctors use it for colonoscopies on their own without anesthesia monitoring. And you kind of snicker, but there are places that do that, and so if I was going somewhere else to have a colonoscopy, I would want to ask, what meds are you going to give me for sedation, and who's monitoring me while you're doing that? Because it's really easy, and I could stand up here and show slide after slide of Michael Jackson and Joan Rivers, and that I still get questions like that in pre-op, or when I'm talking to a patient, they say, "What are you going to give me for medication?" And they say, "Who's going to be monitoring? What's going to happen?" I'm like, well, this is why you're in the hospital, because we know how to handle these medicines safely. One thing that is really kind of unique to propofol, it is pretty good at being an antiemetic. So even a small dose of propofol in the recovery room, like 1 to 2 cc's, I guess that's an old term, 1 to 2 mLs, is pretty good at decreasing the nausea and vomiting. And for patients that have a high risk of post-op nausea and vomiting, a propofol infusion throughout the case can be very helpful in alleviating that. So the induction dose, 1.5 to 2.5 milligrams per kilo. On some frail patients, we'll use smaller doses, so 1 milligram per kilo is fairly common. Again, onset, 1 circulation time, duration about 8 to 10 minutes. Respiratory depression with apnea being very common, especially after bolus doses, but on infusions, it's something that you have to have just constant vigilance to pay attention. Is somebody still maintaining their airway as their levels build up with their infusion? Hypotension, talked about, allows earlier manipulation of the airway than our older barbiturate drugs used to use, so that's really how propofol became the most common induction agent and does decrease nausea and vomiting. Propofol is a wonderful, wonderful drug. I don't do a lot of regional anesthesia or blocks, and I use Scott Hoffman's line that there is no block that cannot be made better by the addition of propofol. Just a real quick coverage of barbiturates. When I trained, thiopental or pentothal was our go-to drug. That's what we used for induction the vast majority of the time. I have, crossed the boundary now. It's not even commercially available. It's not made in the world anymore. And that has to do a lot with social circumstances, because the companies that were making it stopped doing it because they were using it for lethal injections. So it was primarily being manufactured in Europe, and the European Union refused to export it. So that's why we don't have pentothal anymore. So the only barbiturate that we're using right now is methotrexate or Brevitol. It's a CNS depressant, but just like propofol, it does not have any analgesic properties. It does have some vasoconstriction properties within the brain. There's the induction dose of 1 to 1.5 milligrams per kilo. It produces unconsciousness in about 1 circulation time as well, and its duration of action is about 5 minutes, 4 to 7 minutes. Now, if we accidentally inject that into an artery, if it for some reason would get hooked up to an intra-arterial line, it can cause intense vasoconstriction, immense pain, and the vasoconstrictions can be so intense and long-lasting it can lead to necrosis, ischemia, gangrene. Even accidental subcutaneous injection, like if an IV infiltrates and we give Brevitol, can cause a lot of local tissue necrosis and irritation. So we should be paying attention to that very carefully and may need to do some interventions if there is an extravasation of barbiturates. Again, there's the dose, circulation time, is its onset, duration. It never really supplanted pentothal, even when we had pentothal available. I don't really know why. And about the only thing that we use it for now is we use it for induction of some ECTs. So we'll also use it on occasion when they're doing some neuro testing in the MEG scanner, but otherwise we rarely use methotrexate today. Ketamine is kind of seeing a little bit of a resurgence. It is the only medicine that's in this class of phenylcyclidine derivatives, so it is pharmacologically related to LSD and apparently has some street value because veterinarian offices use ketamine a lot and they get broken into routinely and their ketamine gets resold on the streets as Special K. But the reason that it's called a dissociative anesthesia is it really kind of creates this out-of-body experience where the mind isn't really linked to the body anymore. Hallucinations can be very common, psychotropic effects. and a really increased in distorted sensory perceptions. So people say that they can hear colors and they can see sounds when they're taking ketamine. So we generally give ketamine in conjunction with benzodiazepines. If you're going to give someone ketamine alone, you either need to warn them about the psychotropic effects, or we give benzodiazepines to try and that will decrease the psychotropic effects, or at least give them amnesia so that they don't remember that they had that effect. But the one reason that we love ketamine, it is a very, very potent analgesic agent. Even a small dose of 5 to 10 milligrams, way under what an induction dose would be, can provide really great analgesia without the opioid effects. It doesn't on its own produce complete amnesia. The other nice thing about ketamine is it's very good at preserving airway reflexes. It does cause some increase in salivation, so sometimes we'll give it in conjunction with a med to dry up secretions, an anticholinergic like glycopyrrolate. But ketamine will keep someone spontaneously breathing. It's a bronchodilator, so we use it for patients that are wheezing or at risk for bronchospasm. And it produces direct sympathetic stimulation. It causes release of norepinephrine. So it will increase cardiac output, increase heart rate, and increase patients' blood pressure. So we'll also use it for induction in patients who are hemodynamically unstable. So one of the nice things about ketamine is we can give it IM. So for patients that we can't get an IV in, that we don't really want to do an inhalation induction, say a mentally challenged adult who would be a patient that would take a long time to get to sleep with a inhalation technique, we'll do IM ketamine for those patients. IV, it's a very short circulation time. IM, kind of variable depending on where we're able to get the medication in. We generally say it's 5 to 10 minutes, but it can be a much shorter time than that. So if we give somebody IM, we need to be prepared to get them in a place where they can lay down real quickly. I remember one time Clayton was helping me with a patient that we had chased into the bathroom, and we were doing an IM injection, and luckily I was really so thankful that Clayton was there, because he had to carry her out of the bathroom. Because she just went down right away, and I wouldn't have been able to get her out myself. But the things we need to remember, it does increase cardiac output and blood pressure because it inhibits the reuptake of norepinephrine. So useful for patients in shock, asthma, patients with some congenital heart disease. This is pretty much our go-to agent for patients that are having cardiac tamponade and need a pericardial window. And because of its analgesic properties and its hemodynamic stability, also very frequently used in the burn unit for dressing changes and treatments up there. We don't use it for patients with increased intracranial pressure, because the catecholamine increase will increase intracranial pressure in those patients. Etomidate, very useful for its cardiovascular stability. So we'll use these, say, in a trauma patient, someone who has low blood volume or is in shock. It is not an analgesic. Even a single dose of etomidate can cause adrenocortical suppression. So if somebody already is at risk for having low steroid level, we need to be concerned about that. Yeah? Can nurses give ketamine? I think it's in that class of medication that is considered in the deep sedation category. So I don't think so. Yeah. Yeah, I think it falls under that extra pair of hands concept through the State Board of Nursing, that if the physician is engaged in a procedure where they can't safely disengage from the procedure to give the medicine, then the RN can give it in that way, as long as it's the the person who's giving it or who's ordering it is there. But yeah, I think ketamine and etomidate and the barbiturates fall under the extra pair of hands concept. I just haven't seen if that's been revisited in the last couple of years, so that's why I was hesitating there a little bit. Etomidate, when we give it, frequently we'll see myoclonic movements, and so it looks like maybe patients are having a seizure as they are, as the etomidate is circulating, so that's just something to be aware of. Etomidate also causes a little increase in nausea and vomiting. There's the induction doses, 0.2 milligrams per kilo. Again, just like all the other ones, onset of circulation time and lasts about 5 minutes. So for the opioids that we're using, the ones that we use intraoperatively, primarily fentanyl, sufentanil, morphine, remifentanil, and hydromorphone or Dilaudid. You know why we give opioids. There's our adverse effects of opioids. There's quite a lot of them. Primarily, we're concerned about respiratory depression, vasodilation, stiff chest, but we also, of course, have to treat things like nausea and vomiting, itching, and urinary retention. So fentanyl is the one most commonly used intraoperatively. There's a lot of routes that we can deliver fentanyl. We can spray it in the nose for a patient that doesn't have an IV. We can give it transpulmonary. They worked for a while on trying to get like a inhaler type of delivery system for patients, chronic pain patients, to have. I think that one and the fentanyl lollipops have all kind of fell out of favor because they're so easily confused with things that are not medications or that are other medications. You'd hate to have somebody, an asthmatic accidentally grab the fentanyl inhaler instead of the Ventolin inhaler. So that really didn't take off. But so primarily we're giving it intravenously, rapid onset of action, and duration of about 30 minutes. Morphine seems to have a little bit more histamine released, more vasodilation, and more itching, nausea, and vomiting. I think that's probably why morphine has kind of fallen out of favor. Sufenta is rarely given outside of the OR environment, but Sufenta is the most potent narcotic that we have. Its onset of action is about 3 minutes. It has a longer duration of action. It says 30 to 60 minutes in the books. Realistically, it feels like a little bit longer than that even. But one of the issues that we have with Sufenta is if we have a patient who is spontaneously ventilating, or if we're using Sufenta as we're putting someone to sleep, is we get a greater incidence of stiff chest and muscle rigidity, and can make it very difficult to ventilate those patients. Remifentanil is ultra short acting. So we give it as an infusion, and when we stop giving remifentanil, its effect goes away in about 5 minutes. So a key point is when somebody is using remifentanil, if there is going to be pain after the remifentanil is stopped, there needs to be some transition medication that's going to last longer, because it's a problem when somebody shuts the remifentanil off and doesn't have any other analgesic on board, then they're going to need something rather quickly. We use it in conjunction with propofol a lot for TIVA anesthetics. This is the technique that we're primarily using in intracranial cases. So if we're giving infusions of our narcotics, remifentanil, no matter how long your infusion lasts, this is how long. The context halftime is how long does it take for 50% of the drug to go away. No matter how long your infusion of remifentanil lasts, it's still going to go away 5 minutes after you shut it off. So remifentanil does not have a buildup effect after a prolonged infusion. Interestingly enough, sufentanil also does not. After a couple of hours of Sufenta infusion, that's the green line, your duration of the effect is the same. So Sufenta doesn't accumulate in the tissues. Fentanyl, on the other hand, a fentanyl infusion will continue to accumulate probably for as long as you're giving the infusion. So within 2 hours, we've got a prolonged effect of fentanyl, and the slope of the line just keeps going up and up and up, and we don't really know what the peak is for fentanyl. So fentanyl on a prolonged infusion can have a very long duration because it does accumulate in the tissues, which will be coming out slowly. Wow, I'm just stunned at how much hydromorphone or Dilaudid we use now. And it worries me because I am concerned about postoperative respiratory depression related to Dilaudid. One of the issues is it has a long duration of action, which is great. It's a really nice drug for transitioning patients out of the operating room, but it also has a little bit longer onset. So I see people who aren't really experienced using it, they'll treat it like fentanyl. They'll give some Dilaudid. 5 minutes later, they'll give some more Dilaudid, then they'll give some more Dilaudid, and all of a sudden you're at a really high dose of Dilaudid. So I think that's something that we need to keep an eye on, but I'm just kind of impressed. And this is not just here. When I talk to people at other places or I look at the literature, we're very similar to their other places' uses of increase in use of Dilaudid. So if we compare opioids, if we use morphine as our base, so if morphine is 1, fentanyl is 100 times more potent than morphine. Sufentanil we consider 1,000 times more potent than morphine, and Demerol is only about a tenth more potent, tenth as potent as morphine. So 10 milligrams of morphine is equivalent to 100 mics of fentanyl, which is equivalent to 5 to 10 mics or 10 to 20 mics of sufentanil. And then here's some conversions in both the oral and the IV forms, and so those are about the same. All right, I'm going to have to talk a little bit faster because we still got a lot of stuff to cover. Inhalational anesthetic agents. I put the little X over Ethrain because they don't make that one anymore. These are the drugs that have been used for inhaled anesthetic agents since the first ones in 1840s. So the ones that we're still using today now are Sevo, desflurane, isoflurane, and nitrous oxide, which actually was first used, discovered in 1799. So nitrous oxide, great drug, great analgesic, not a complete general anesthetic though by itself. It has great analgesic properties, but really only an analgesic while you are delivering the gas. So again, if we're going to have pain that lasts after a procedure, we can't count on nitrous oxide to produce any long-lasting pain relief. Very minimal cardiovascular and respiratory depression. I tell the students to think of it this way. If it is safe enough to give in a dentist's office where their emergency plan is to call 911, it is a very safe drug. Doesn't cause cardiovascular respiratory depression. It does, however, expand air-containing spaces. It has an affinity for airspace 35 times more than nitrogen. So it will move into an airspace and displace the nitrogen out. So we do not give it in any cases where we are concerned about an abnormal airspace. So for instance, a trauma patient that may have a pneumothorax, if we have concerns about a patient with an air emboli, if they're even a patient with a bowel obstruction that may have trapped bowel gas, you shouldn't use nitrous oxide. Or if we're doing a surgery that will potentially end up with a trapped airspace like an inner ear reconstruction after they put a tympanic graft on. You don't want to have an air bubble behind it that's getting bigger from the nitrous oxide. So this just shows, these are dogs. Oh, it kind of makes me sad. I'm like, they gave dogs pneumothoraxes. But if they had the dogs breathing 100% oxygen, the size of their pneumo didn't change. If they had them breathing 75% nitrous oxide, within 20 minutes, the size of their pneumo had doubled. So that's why we don't use it in those kind of patients. An issue with nitrous oxide, when we stop delivering it, because it wants to move to an airspace, it will move to the biggest airspace in the body, which is the lungs. It will displace oxygen from the alveoli out of the lungs, and it will do it rather quickly. So we need to be giving supplemental oxygen after we're giving nitrous oxide to prevent that diffusion hypoxia. It only lasts about 5 minutes. So the black line is the oxygen levels. The white line is nitrous. So as the nitrous is coming out of the body, the oxygen is dropping. But after 5 minutes, 5 to 10 minutes, the nitrous oxide has all been eliminated from the body and the oxygen levels will come back up. So it's a short-lived effect, but another good reason that everybody after anesthesia deserves some oxygen. So what do inhaled anesthetics do to the respiratory effects in the body? They decrease the ventilation, and it is a central effect, so it occurs in the brainstem. When patients are spontaneously breathing under inhaled anesthetics, they will breathe at a slightly faster rate than normal, but they'll breathe much more shallow. So they have a decreased tidal volume. And they also breathe very, very regularly. In normal ventilation, people will sigh, they'll yawn, they'll adjust their ventilation mode to overcome the atelectasis in your lung bases. That doesn't happen under inhaled anesthesia and spontaneous ventilation. So people will breathe very, very regularly, but very shallow. So this is a really overwhelmingly busy slide, but carbon dioxide levels go up, tidal volumes go down, minute ventilation goes down, and respiratory rate goes up. So this just shows a little bit faster rate, but shallow, small breaths that people have under anesthesia. An important point for recovery is that patients have a decreased sensitivity to carbon dioxide and a decreased sensitivity to hypoxia. Normally, our brains want to keep our carbon dioxide level between 35 and 45. Patients who are COPDers may have a little bit higher set level of carbon dioxide, but a patient who has anesthesia on board, their carbon dioxide may need to be in the 50s or 60s before they spontaneously breathe. Likewise, patients can be hypoxic and not alter their respiratory pattern to change their hypoxia. That is why everybody should be on a pulse oximeter and should have supplemental oxygen. There is some VQ mismatching and hypoventilation that also occurs with inhaled anesthetic agents. But this just shows that even 0.1 MAC, and we can bring patients out of the operating room, they can be awake, we've extubated them, and it is very, very common for patients to still have 0.1 MAC of agent when they are coming to the recovery room. They can have a 50% response to hypoxia. Or in other words, they only change their ventilation half of what they should normally change it if they were wide awake. Inhaled anesthetic agents are all vasodilators, so they decrease systemic vascular resistance, and it's dose dependent. So the more anesthetic they have on board, the more vasodilation they have. They all decrease blood pressure at the same rate. So again, they're all somewhat cardiac depressants. Isoflurane is still in use. Sevoflurane is the one that we use for inhaled inductions because it's the best tolerated, it's supposed to smell the best. And desflurane has some issues that make it a little more difficult to deal with because it's difficult to keep in a liquid form. So because once its boiling point and its atmospheric point are close to normal conditions. So it takes special bottles and vaporizers. But the key point are they're all very fast at putting someone to sleep. They generally wake patients up. Sevoflurane and desflurane have a faster emergence than isoflurane does. All right, I'm going to just keep talking. So neuromuscular blockers. So we've got two classes, depolarizing neuromuscular blockers and non-depolarizing neuromuscular blockers. Depolarizing means it acts like acetylcholine in producing an effect at the neuromuscular junction. Non-depolarizing inhibits the acetylcholine. So the key points are either it acts like this and fills this channel, or it inhibits these channels and doesn't prevent, either way, it doesn't prevent the response to move through the neuron and create an action in the muscle. So the only depolarizing neuromuscular blocker that we have is succinylcholine. This is the whole list of things that just in my career we've gone through in terms of non-depolarizing neuromuscular blockers, but at one time Dr. Chuka made me use curare. We don't use curare anymore. We don't have atracurium. Mivacurium is off the market, and sometime we can have a discussion about mivacurium. Doxycurium is off the market, and pipicuronium is off the market as well. So we're left with vecuronium, cisatracurium, and rocuronium primarily. We can still get pancuronium if we absolutely beg pharmacy for it, but it's a little difficult to get. So why do we use neuromuscular blockers? Because it makes it much easier to put a breathing tube in when somebody isn't coughing and trying to breathe at you. So we also use it for surgical relaxation for patients that need more control of mechanical ventilation, status epilepticus. I've never seen tetanus, but can use it to modify the muscle spasms in tetanus. And again, these are not anesthetic drugs. They do not put someone's brain to sleep. They just prevent someone from moving when they're awake, and they are not analgesic. So if we're using neuromuscular blockers, we absolutely need to give sedatives as well. So what's the difference between depolarizing and non-depolarizing? When we give a depolarizing, when we give succinylcholine, we get fasciculations. In other words, we get uncoordinated muscle contractures all over the body. We do not get that with the other non-depolarizing. The things that happen with the non-depolarizing is if you put a nerve stimulator on and hit the tetany button, you get some fade that will occur with that. If you do tetany and then test the nerve stimulation again in a couple of minutes, you'll get an increased response, and the non-depolarizing neuromuscular blockers are reversible. So here's what we're looking at when we do the train of 4. If you have someone with no drugs on board, they get 4 strong muscle twitches at equal height. If we give them a non-depolarizing block, the first twitch is high, and then it decreases to the 4th twitch, if you even see the 4th twitch. Sometimes we'll only see 2 or 3 or only 1 twitch. For succinylcholine, they still have 4 twitches of the same height, but they're much less than the normal one. And then there's phase 2 block, and we're not going to cover that. That's anesthesia 201. Is you may get a train of 4 like response, but so the difference we're not usually measuring a twitch in succinylcholine because we're just going to get 4 twitches. How do we decide which neuromuscular blockers we're choosing? Speed of onset, duration, and side effect profile. So our long-acting neuromuscular blocker that we have is pancuronium. The intermediate ones are the other non-depolarizing. There is no short-acting non-depolarizer. That's the holy grail that we're still looking for in anesthesia. The only rapid onset, very short-acting one that we have is succinylcholine. So that's why that one has, even though it has some issues, some concerns, that it is still very much in use today. Okay, so if we look at succinylcholine, that's the molecule of acetylcholine. Succinylcholine is just 2 of these acetylcholine molecules put together. It has a very rapid onset of action. And so that's the goal. When we're doing a rapid sequence induction, if we don't want to risk someone having their stomach contents come up into their lungs all over me, we want rapid onset of action. So we're given succinylcholine. It's metabolized by plasma pseudocholinesterase, and it is so well metabolized in the body that actually only 5% of it gets to the neuromuscular junction. So the adverse events of succinylcholine, a lot of cardiac dysrhythmias. It produces a release of potassium, so we get hyperkalemia. Patients complain of pain because of the fasciculations and this uncoordinated muscle activity, and can cause increased pressure in the eyes, the brain, the stomach, and it's a trigger for malignant hyperthermia. So there's a lot of problems with succinylcholine, but because it's the only short-acting, fast onset one that we have, it's been, continues to be a great drug. So neuromuscular blockade really sucks. Vecuronium, good drug, minimal cardiovascular effects, very stable duration. Cisatracurium doesn't depend on being metabolized by the liver or the kidneys. It's metabolized by Hoffman elimination, which occurs in the plasma. So it's a great drug for patients who have renal or liver dysfunction. Also very cardiovascularly stable. Racuronium, fastest onset of the non-depolarizing neuromuscular blockers that we have. And so we use it for modified rapid sequence inductions when we don't want to risk giving succinylcholine. And pancuronium, longest half-life. We also like it in NICU babies because it increases the heart rate. It's primarily why we don't use it a lot in adults, because it increases heart rate. We've got reversal agents. I'm going to zip over those because the complications of reversal, well, let me cover those quick. So if we just give an anticholinesterase inhibitor, we'll see bradycardia, salivation, urination, defecation, hypotension. So that's why we're giving an anticholinergic as well. So we give both of them together so that this drug blocks the effect of the other drug that we're giving to reverse the effect of the first drug that we gave. It's a nice little domino effect that we have to do. How do we know if a patient is adequately reversed? The key is, the best one is a sustained head lift for 5 seconds. Grip strength is pretty difficult to quantify. If someone's on a ventilator, if they can draw vital capacity breath of 20 mLs per kilo, that's also a very adequate response. All right, I'm going to cover recovery quick. Barb, is it okay if I just keep going? I'm going to take about 5 minutes more. Dr. Heiser seems okay with that. So what things are we really concerned about during recovery? Primarily airway and cardiac issues. As an anesthesiologist, really my concern for the body kind of stops at the duodenum. There's important things that go on down below that. I actually cover, I guess for me, it's important to go to the liver. But anything below the umbilicus just really isn't that important. But airway, breathing, circulation, and somebody not vomiting and aspirating, those are all things that we're really concerned about. But primarily we're concerned about airway first and foremost. We want to make sure that we don't have loss of muscle tone. Watching for adequate breathing patterns is very important, and not getting the paradoxical breathing when someone is obstructed and their chest goes down and their abdomen goes up is an important thing to watch for. We want to make sure that we address or pay attention to any residual neuromuscular blockade. Perhaps the patient got neuromuscular blocker and did not get reversed, or got a longer acting dose of medicine and the reversal has worn off. Just like the flumazenil can need to be repeated, we may need to watch for a recurarization of neuromuscular blockade. Look for a laryngospasm, airway edema, and sleep apnea. We need to do maneuvers or measures to maintain airway in the recovery room. Postoperative delirium can happen. The biggest thing that you should think about when a patient is agitated or delirious is hypoxia. And the residents hopefully have it drilled into their head that agitation and delirium is hypoxia until proven otherwise. Even if the oxygenation is fine, if a patient is underventilating and their CO2 levels are high, they may show some signs of delirium. It may be medication effects. We give a lot of things that affect the brain: anticholinergics, benzodiazepines, inhaled anesthetic agents. We've got other drugs or alcohol that the patient may be withdrawing from, and then the other issues of postoperative delirium. Postoperative nausea and vomiting. The four main risk factors are a previous history, or if they have motion sickness, women, if they're getting opioids, and if they're non-smokers. And even if you don't have any of those factors, you got a 10% risk of post-op nausea and vomiting. One risk factor gives you a 20%, and then 40, 60, 80%. So if you got all four of those factors, you got an 80% risk of having post-op nausea and vomiting if we don't do any interventions. And this is just a little slide that shows that in chart form. So here's the risk factors for post-op nausea and vomiting. This came from the consensus statement that was just put out last year by the American Society of Anesthesiologists. So how do we reduce risk? Well, if we avoid general anesthesia, wouldn't that be great if we could do that? I talked about using propofol and avoiding nitrous oxide. Hydration can be a very important point, just making sure that the patient has enough fluids. I like to give my tonsillectomy patients at least 500 mLs of fluid if they're even if they're like a child, because hydration can really decrease your risk of nausea and vomiting. This is something that is, it was interesting to me that I hadn't really seen noted before this consensus statement that came out from the ASA, is they've now got a risk score for post-discharge nausea and vomiting, and the risk factors for a patient going home include being a female, history of post-op nausea and vomiting, age under 50, if they got opioids in the PACU or if they got nausea in the PACU. And you can see again, as you add each one of these factors, if you have all 5, you have, again, about an 80% risk of having post-discharge nausea and vomiting. So that may be something that we're going to need to address as well. These are the pediatric risk factors for nausea and vomiting. A long surgery, age more than 3, and strabismus surgery, which we don't do very much of here. But if a history of post-op nausea or post-op vomiting in first-degree relatives, parents, siblings, like that, that is a risk factor for them to have post-op nausea. And this is the treatment algorithm. I know it's really small and it's going to be hard to read. This may be one that we want to have blown up a little bit bigger, because this is again from that consensus statement, and it has the risk factors, and then what can we do to decrease the risk. And if we have someone that we decide is medium risk, we can address some of these issues, giving patients dexamethasone intraoperatively, putting on scopolamine patches, using 5-HT3 antagonist, using other antiemetic meds, running a propofol infusion during the case, other medications, including droperidol. Would be great if that came back. So I talked a long time, covered a lot of stuff. Some of it was kind of quick. What questions do you have? Haldol can be really effective for nausea and vomiting. I think it's probably a little more effective if you give it early, but I don't know if it's approved here. Have we given Haldol? Yeah, it's not on our algorithm right now, but it probably should be. Yeah. For the patient that had the seizure, should Ativan have been the first drug of choice? It doesn't matter which benzodiazepine it is. The key is treating it as soon as possible and not delaying treatment to get a different. So if you have a Versed available, Versed is just fine as an anti-seizure treatment. Okay, so why do the kids that get the LPs use so much propofol? Well, it's a painful procedure, and so they're not getting any analgesics with that as well. So they need to be at a really, really deep level of sedation, almost general anesthesia level, to tolerate that procedure. The other thing is when we're doing the kids for like the radiation treatments, even though they're not getting anything painful, as the course goes on, it seems like we continue to have to increase our dose. So I think there's probably some tolerance effect of repeated exposures to propofol. And then just in general, kids seem to need greater doses of propofol for their body weight than adults do. Probably has to do with their volume of distribution. They've got more fat stores.
At what age do you not want the scopolamine patch given to the elderly because of confusion? Is there kind of an age that you go by?
That's a good question. Is there an age at which we don't put a scopolamine patch on? Because there is a definite decrease in nausea and vomiting as people get older, I generally am not as aggressive in treating, prophylactically treating post-op nausea and vomiting in patients over the age of 70. So that's kind of my cutoff. I don't have any literature to back that up, but I think that's a good point is, yeah, we do need to be concerned about, especially the polypharmacy in the elderly people. Other questions? I would be happy to talk about anything that I've covered today if any of you see me and have questions about anything, but thank you for your time.
Just do a 5-minute break real quick, and then Dr. Heiser's ready. He's ready.
Barbie,
Yeah.
who wants to keep recording?
No, that's it.